All right, we're into our first formal lecture, and my kids thought it'd be fun a couple semesters back to give me some jokes. They like to write these jokes, and so I have a stack of jokes, and every time we get together I thought I'd tell you one. Okay? Some of them are out of Highlights magazine, so they're kind of summarized out of there. Others are their own. Sometimes you can really tell. So we'll see if it works. Remember, keep in mind, one of them just turned 9 yesterday, so she is a year older and wiser. But their ages are 5, soon to be 6, 9, 10, and then 12. So, all right, here we go. Why do frogs make good outfielders? Anybody? Why do frogs make good outfielders? They like to catch flies. Pretty close. Because they're excellent at catching flies. All right, so that's our first joke of the semester, and we have a lot more. You guys want one more? Yeah. Where do cats wait to pay their bills? Where do cats wait to pay their bills? In the feline. All right. So a couple of announcements. Everyone should have finished pre-quiz number 1. And I sent you an announcement yesterday as a reminder because it was a holiday. It's the early of the semester. Every week I won't send a reminder. I just wanted to make sure that you didn't get thrown off by the day. Okay? Did you guys do anything fun yesterday for your holiday? Nothing? We celebrated my daughter's birthday. We joked that the whole country took the day off for her birthday. I mean, when you're 9, that's kind of a big deal, right? But she's bright enough to know that it wasn't technically a day off for her. She knows that there was somebody that's done something pretty substantial. So, but yeah, we had a good day. She wanted to ski. She wanted to go to Karma and have sushi, and then she would get soup, and then she wanted to go to a movie. So I was exhausted last night. That was a pretty busy day, but we had a lot of fun. All right, so the format of this class as we get started, we're going to have a 2-hour lecture today. We'll probably stop about 1:15. Okay, hour 15, hour 20 to give you a little bit of a stretch. I like to go a little beyond the halfway point because a lot of you are used to Tuesday, Thursday lectures, so those are 1:15. So you can kind of fight through to that point, and then it's downhill from there. It feels like downhill from there. Okay, bless you. So hopefully you spent some time in the chapter. If you don't have your textbook, I did post a PDF of the textbook. Did anybody find that? PDF of chapter 1, not the whole textbook. Someone's like, really? You're telling me after I bought the whole? No, you need the whole textbook. But chapter 1 I actually have as a PDF in the BB Learn shell under resources. Okay? So if you're cruising around in there, you could have found chapter 1. There's going to be a post-quiz that's due on Friday. Friday it's due by 11:59 p.m. Okay? So, again, don't count on the reminders every week. By this point in your career, you should be used to it. But I wanted to get you guys off on the right foot. I didn't want you to miss the first quiz because of yesterday being a holiday. All right? So, as we move into this first lecture, the idea is that you should be reading ahead. So you should have read this chapter, and this chapter is the introductory chapter, which is chapter 1. Next week, we're going to be in chapter 2. So you should be reading ahead in chapter 2. And I'm quoting 8th edition pages. Again, there's that 8th to 9th edition page conversion, but I think these two first chapters are pretty much the same. The pages might be a little bit off, but the chapters are the same. And then the other thing I want you to do is I want you to look forward in the lectures. So it's not just reading the text, it's actually looking at the lectures. And so those pre-quizzes questions are going to be taken off of the readings and or the lecture slides or some combination of the two. Every now and then there may be something you have to quickly look up, but it's going to be pretty simplistic as far as a search is concerned. Friday might be a little bit more complicated. You don't have to wait until Friday. You can take it tonight. You can take it tomorrow. You can take it Thursday. Okay? Just do it before Friday at 11:59 p.m. If you know you're working an evening shift on Friday, then maybe don't wait until you're done working. You might be exhausted. You might be tired. You have to do it in one sitting, just like what you had with the pre-quiz. I didn't get any mass emails saying it doesn't work. I checked your grades. They all reported correctly. So it looks like we don't have any electronic issues right now. So we shouldn't anticipate any big ones in the near future.
Post-test the same like?
Post-test is the same like, different questions, and the level of difficulty goes up a little bit on the post. Okay? So that's kind of the whole plan, is by the end of the week, you've increased your knowledge base and you can perform at a higher level. All right, so we introduced last week when we were together, we talked a lot about syllabus, we talked about the schedule. The value of doing that is I didn't get any emails saying, oh crap, I missed the quiz, I forgot. So nice job, but you guys are professionals, you've been doing it for a while, so you know the drill. But we talked also at the end, we talked about Barrett esophagus, and we're going to continue in this theme of pathology, which we said was the study of suffering. We also know, and actually this is one of the, I'm not sure if you have this question, there's a pool of questions, usually a poll, so there's a few that might be different for each of you, and you may not have had this question, but one of the possible questions on the pre-quiz was this, that pathology is the study of suffering. It also bridges clinical practice and basic science, so it's very translational. And those two options were on one of the questions, and then I think it said two of these are correct. Okay? So that's also trying to get you ready for the exam, where instead on the exam, instead of just two of these, you're probably going to have to know which ones. Okay? Instead of just saying, well, is it two of these, or is there one that's actually, or is it all of the above, and if I can eliminate. On the exam, it'll probably be A and B only, or B and C only, if there's two options that are correct. So I'm trying to slowly get you ready for the exam-style questions as well. The other thing that it does is it does investigate a lot of the causes, or the etiologies. And it also investigates a lot of the underlying mechanisms. So we're going to see that unfold even more today as we look at our lecture. But first off, we need to talk about cellular adaptation. So if we dive deep microscopically into the cell, we can see on this slide, and this textbook has a lot of these kinds of flowcharts, a lot of these diagrams. And you can see the normal cell at the top, and it's going to experience some level of stress, and it has the ability to adapt. Our cells have the ability to adapt. In fact, there's a very special gene that's coding for a protein known as P53. And P53 is labeled as the central monitor of stress in the cell. And so a lot of times throughout our day, when you're walking to class, and let's say it's a nice sunny day, like we get an awful lot in Flagstaff. My kids are, I tell them they're totally spoiled. They won't realize how spoiled they are until they grow up, move away, and realize that, not every place you get nice snow and it's, 45 degrees and sunny. Because they wake up and say, we're going skiing today? Is it a bluebird day? Like, yes, it is. All right, let's go. Right? They don't want to ski unless it's nice conditions. But the other thing that we know is in that sunny weather, there's a lot of UV radiation. And that UV radiation, it can be harmful. It also can be beneficial to us. So we actually have the ability to manage that stress that we get a lot of in northern Arizona. And so P53 is upregulated as a result of the stress. We're going to talk about P53 as a tumor suppressor gene in the cancer section later in the semester. I'm just trying to foreshadow a little bit what's coming up. So P53 is an example of an adaptation that we have that normally kicks in when you have stress in your environment, like sunlight. Unless you live in a hole in the ground or in Minnesota, then you see the sun, okay? I'm just picking on Minnesota because I was there a lot in the last couple of years in the wintertime, and it's really cold. But they don't see a lot of sun. But here in the Southwest, we get a lot of sun. We have a lot of other issues. If you grew up in Phoenix, you know there's days that are no burn days. You know, there's pollution in the environment, and that pollution can cause problems and increases of stress. Those are chemical stress agents. So we're going to look throughout the semester at different types of stressors that cause damage to the cell. Air pollution can do that. High levels of ozone. High levels of UV radiation that come from sunlight. Okay? Asbestos or chemicals. Okay? Carcinogenic agents that are found in cigarette smoke. That's why there's all these new legislations around, don't smoke next to the giant intake for the building. You see those giant vents, and there's like benches outside, and it says no smoking, because they don't want you smoking and then them piping all of the exhaust into the building. So we'll see a lot of these examples, and the body does a pretty good job of adapting. Well, sometimes there's an inability to adapt, and that creates some deleterious or negative cell injuries, and we'll look at those. If the cell injury continues, you may see some things that can be reversible if the stress goes away. Like what we saw with Barrett's esophagus. We know that there were alterations that took place. Metaplasia was the word that we used. And it went from one phenotype to a different phenotype because of this stress that was there. What was the stress? Was it UV light? No, what was it? Hydrogen chloride from the gut, from the stomach, that's coming up with this acid reflux in the esophagus. Esophagus is not built to handle that. And so it changes its phenotype. It alters. You remove the reflux, the heartburn, the gastroesophageal reflux disease. You quench that. Well, then the architecture of the epithelium goes back. It is reversible to a certain point. Well, there are other subcellular alterations that we'll look at. We see changes in the cell membrane. We see changes in the endoplasmic reticulum. We see changes at the level of the nucleus. There is a point at which it's irreversible. And now we get into this bucket or this category known as necrosis. So a lot of times we look at normal, healthy tissue, and we look at necrotic tissue. And clinically, that's probably what you'll spend most of your time looking at. But there's a lot of stuff that happens in between. And sometimes a patient will present, let's say they're backcountry skiing, and they get lost, and they're exposed to the elements, and they present to the emergency department with frostbite. And the question is, well, is it past, can we save it? That's the question they ask clinically. Well, what they're really asking is it past this critical point of irreversibility? Meaning we're going to lose the toe, or the foot, or the hands, or the fingers, or can we rescue it? Okay, so that's kind of what that line is. And that gives you a picture of how this material actually relates to what you're probably going to be doing in the future. That's one of the reasons I really do like these sequences of courses that I get to teach, A&P and also pathology, because many of them are students like you. They're going to go on and be my future doctor, my future nurse, right? My future PA. And I get to deliver it hopefully in a format that you find interesting because of what you're going to be doing in the future. And so this point of irreversibility is our scientific way of saying, clinically, can you save the limb? Okay, or the appendage? Well, if it's not salvageable, then it becomes necrotic tissue. It's dead tissue. It's going to die. And we'll look at what that necrosis is. Well, we're also going to talk, you can see over here, cell injury can also lead to some other types of adaptations. And we're going to sort of compare and contrast in today's lecture the differences between necrosis, which is really just the point of not being able to save it, and what we call programmed cell death. And that's what apoptosis is. So there are certain things that are going to trigger a signal in the cell to say, you know what? I'm going to move out of this tissue in an organized fashion. And it legitimately packages things up, kind of like in U-Haul boxes, and labels them. And it does that in these little vesicles, so the body can actually recycle those parts. So this is very organized, known as apoptosis. This is very disorganized, known as necrosis. Both of them can be a result of cell injury. And we'll talk about some examples there. And in some cases with apoptosis, there are examples that happen even during development.
that are actually not a result of a harmful toxin or a chemical or a harsh agent. They're actually part of the genetic code that says, hold your hand up for a second, everybody. How many of you have 5 digits that are clearly delineated? Right? Now, if in development there was no signal to destroy the cells or to program the death of the cells in between the digits, then they have skin there, and there's a webbing. So in utero, that webbing actually goes away due to apoptosis. So that's an example of a normal apoptotic mechanism that isn't a result of a disease. Okay? All right, if you still have your hands up, you can put them back. All right, so let's look at cellular adaptations as we walk through today. We're going to look at physiologic adaptations as well as pathologic or pathogenic. Physiologic are a result of a normal process. It might be just growth. It might be embryonic development. It might be repair. These are normal processes that take place. Pathologic cellular adaptation. This is a result of a disease state or something that's perturbed the system. Trauma, like a car accident. Frostbite, from being lost out in the wilderness and being exposed to the elements. A laceration, okay? A burn, whether it's a chemical burn or whether it's actually an open flame. Those would all be pathologic adaptations or pathogenic. Atrophy, what does atrophy mean? What does that word mean? Shrinkage, cellular shrinkage, or a decrease in cellular size. Hypertrophy is the opposite. That's an increase in cellular size. How about hyperplasia? An increase in cell number. These all can be mutually exclusive events, meaning they can happen independent of the other. In many cases, they may happen together, like hyperplasia and hypertrophy. The example, normal physiology of hyperplasia and hypertrophy is the normal female menstrual cycle. You get an increase in cellular size in the endometrial lining, and you also get an increase in cell number. Metaplasia. What is metaplasia again? A change in type. So you go from one phenotype of cell to another one. What was the example we've already covered? Bare esophagus. Okay. We're going to talk about another one here in a moment of metaplasia, and that's going to be in chronic smokers. Where in chronic smokers, we've got the epithelial metaplasia of the lungs, where the normal ciliated columnar epithelium is now replaced in the trachea, and the respiratory bronchi are replaced with stratified squamous epithelium. So it's just the opposite of what happened with Barrett, right? So normally in the respiratory lining, it is a ciliated columnar epithelium. Well, with all of the harmful toxins and agents and pollutants that are within cigarette smoke or tobacco smoke, that actually over a long period of time, we're not really talking about the occasional cigar or pipe. E-cigarettes, someone's going to bring up, we'll talk about that in the respiratory lecture. Okay, they're not necessarily considered a safe alternative. So the FDA has actually said that already. We were in the theater yesterday, you're seeing more of these signs being reordered, right? No smoking, that includes e-cigarettes. So that was in the theater, no smoking including e-cigarettes. Because we don't really know, the jury's still out. The manufacturers, of course, tell you they're a safe alternative. But they are a little bit conflicted, aren't they? Because they would love to sell you their product and say that it's a safe product. So we're not going to necessarily listen to them. We need the regulatory body, which is the Food and Drug Administration, to actually evaluate, is it truly safe? Now, my opinion, here's my opinion. It's probably safer, but is it a risk-free solution? No, absolutely not. But of course, there are no risk-free anythings really, right? Life is a risk. So is it a safe alternative, and should, 12, 13-year-olds start using e-cigarettes? In my opinion, probably not. Okay. But we'll talk about that more when we get to the respiratory lecture. So metaplasia, we have two examples now, and we'll look at some histology of the adaptations that take place in the smoker's lung here in just a minute. Okay, let's talk right now about this adaptation that we see with cardiac muscle. So we have a couple images here. We've got the normal myocyte up top in this cartoon format. And then we actually have a ex vivo cadaver slice cross-sectionally through the ventricle. This is about mid-papillary muscle, so about halfway down the heart. Okay? And you can see the left ventricle is on your right side, of course, because this is patient anatomical position. And this is the right ventricle shown on your left side, because that's the patient's right. And this is the septum in between. So this would be considered a normal, quote-unquote normal, slice through the heart. If we look at an increase in load, if we stress the heart, you can stress tissues with all sorts of different types of agents. Here it's a physical stress, like an increase in load. We'll come back to this example at the end of the semester when we talk about cardiovascular, but it's a great example to show you it's not always UV light. It's not always tobacco smoke. It's like, all right, he's going to be all over smoking all semester. Well, it's a great example. We'll use it a lot, but it's not the only one. Okay? This one is just an increase in physical load. What happens when you load the biceps brachii or the triceps muscle over time? You get hypertrophy. It enlarges. Well, skeletal muscle and cardiac muscle are very similar. They're both striated, very similar organization, and you can see the hypertrophy of this single myocyte in a cartoon drawing, and you can actually appreciate the real, not live, it's ex vivo, post-mortem, but you can see, look at the thickness of the septal wall, and look at the relative thickness of the myocardium. Look at the free, open ventricular space. That's a chamber, and there's very little open space in this one. Well, what would be the load that it would be responding to? What's that? Hypertension. Who said it? Nice job. So hypertension is high blood pressure. That means that the heart has to beat against a higher pressure load, and so it's exercising every heart cycle. So over time, it actually enlarges. And these patients that get enlarged hearts, we'll talk about heart failure at the end of the semester. And interestingly enough, one of the side effects of chronic heart failure is actually weight loss. These patients get thinner and thinner and thinner because the heart itself is beating nonstop, and it's beating at an increased workload. So even while they're sleeping, it's like they're exercising. So they actually lose weight over time, and it's this disease known as wasting of the body, or cachia. And we'll get there later. Well, if you come over here, if you unload the heart, if it's not past that point of no return, it'll actually go back to where it natively was. Over here, you can see this is cellular injury, where we've got a myocyte that's been injured, typically because it doesn't have a blood supply anymore. This would be an infarction or a heart attack. And the blood supply that's perfusing the heart muscle is gone. And that leads to cellular death, and you get a scar. And all of this yellowish and some of this dark brown, black colored structure is all scar tissue. Okay? So this is reversible. This would not be reversible. Generally speaking, pathologically, when you have a scar, it's not reversible. You can't back up anymore. And we'll see that motif exist throughout all sorts of different systems, like the kidney, like the liver. Scarring of the liver in cirrhosis is not reversible. Okay? It doesn't go back. So this point of irreversibility is relevant for lots of different organs and systems. All right, let's talk specifically about atrophy, or a loss in size, a loss of cellular size or shrinkage. So physiologic examples would be like the thymus. So the thymus is a structure that's located about right here, right where my mic is, just above the heart. It's the largest when you're first born. Okay? It's where T cells mature. We'll talk about those in a couple weeks when we cover the immune section. And these T lymphocytes are your specific immune system that have to be educated on what kind of foreign invaders they're going to go attack. Well, right now, yours is in the process of shrinking. And by the time you're 70, it's super small. It's actually indistinguishable from fat mass surrounding it. So that's atrophy that takes place in the thymus that's normal throughout our lifetime. So that would be a physiologic example of atrophy that isn't unusual or due to a pathologic condition. So if you take the thymus of a 70-year-old, you take the thymus of a 7-year-old, the 7-year-old's got the thymus beat of the 7-year-old by an order of magnitude. Okay? We'll talk more about that again as we go on. Now, pathogenic, this is an example of a pathogenic atrophy. So you see the brain of a young 20-year-old on the left and the brain of an older 80-year-old on the right. And the meningeal layers have been dissected away on the left side of the brain, the left hemisphere, the patient's left. And so what I want you to be able to appreciate is the brains themselves are about relatively the same size. This one might be a little bit larger. It's got it beat by just a little bit. But more obvious is how pronounced the sulci and the gyri are on this 80-year-old. You see how much gap is in between here? There's actually a loss of mass. And the reason in this 80-year-old patient is there's been atherosclerotic disease over 80 years. And so the amount of blood flow to the brain slowly has been decreasing. So as we get older, if we have atherosclerotic disease, which we usually do, blood flow to certain critical organs is slightly less. Not to the point where they're going to have a stroke. Right? This isn't a stroke example. This is just chronic reduction in blood flow over time, slowly. And that makes the tissue malnourished, and so it shrinks in size. Another one that would be pathologic would be deinnervating a nerve. You cut a nerve. One of the most interesting examples clinically would be spinal cord injury. Whether it's up high, so it would be quadriplegia, or if it's down low, it would be paraplegia. Well, not only can the patient not move or stimulate muscle contraction, what happens to the relative size of those distal extremities? They shrink, they atrophy, because if the nerve isn't sending signal to the muscle to have basal tone, then the muscle actually starts to atrophy over time. That would be another pathologic example. So a reduction in blood flow or a loss of nerve innervation. Both would be pathologic examples of atrophy. Hypertrophy, an increase in cellular size. So this is a picture on the far left, and the left image is actually a gravid uterus. So this is a uterus during pregnancy. And the uterus that's been explanted here on the far right is a normal-sized uterus. So you can see during pregnancy, hypertrophy would be an increase in cellular size. It's actually physiologically normal. Okay, this would be a physiologically normal example. You can see histologically, as we said last week, we talked about things that are morphologic changes at the gross level, macroscopic, as well as the microscopic level. I'm just going to dim the lights a little bit so you can see the histology a little bit better. And you can see in panel B and then panel C, these are taken out of your textbooks. Panel B is a normal uterine lining, smooth muscle cells. And you can kind of appreciate that they're almost like a swooping up like this. So these are spindle-like. Right? Spindle-like means they're thin on the edges, and they're kind of a little fatter in the middle, like a spindle. Okay? And you can appreciate over here, this is a nucleus right here of a smooth muscle cell. And if you trace the outline of the cytoplasm, that's not a spindle. That's actually like a spindle that's swollen up into a round structure. So that's hypertrophy on the far right, your right, that shows a hypertrophied smooth muscle from a pregnant or a gravid, gravid uterus. So hypertrophy, Hyperplasia is another example that takes place within pregnancy. Hyperplasia, this is an explanted endometrial lining. And all of this tissue here is all new tissue. This lining that comes down should all be nice and smooth. So all of these sort of folds is all new tissue, hyperplasia, that actually grows during pregnancy. So the physiologic example here of hyperplasia on the normal menstrual cycle. The pathologic example would be smooth muscle cell proliferation or increase in cell number that happens during damage to a blood vessel, like with atherosclerotic lesions. When we damage the inner lining of a blood vessel, then our endothelium that lines that blood vessel, that usually keeps it nice and quiescent, meaning inactive, it actually propagates smooth muscle cell proliferation. That's pathologic. I forgot to give you the examples of hypertrophy, but what would be a normal physiologic example of hypertrophy? The normal menstrual cycle. What would be a pathologic hypertrophy example that we just talked about like 3 slides ago? You guys remember? Cardiac hypertrophy. Okay, so that is a pathologic load due to hypertension. All right, the last one on our list is metaplasia. Metaplasia, this is where we're going to talk about the smoker's lung. Metaplasia is reversible to a certain extent. We looked at this last week with our first introduction of Barrett's esophagus. And we said that it goes from a stratified squamous epithelium, Barrett, to a columnar with goblet cells. In here, we see just the opposite in the trachea. We have 2 tubes that are right next to each other, but they're both for different things. And the injury stimulus here is actually going to be cigarette smoke, or the pollutants that are within cigarette smoke. So you can see the normal columnar epithelium on the left side of the screen in cartoon format. And you can see down here the representation of the histology that it's trying to mimic. And you can kind of appreciate, here's our columnar on our basement membrane. Here's our basement membrane. This nice thick pink line. This is the hematoxylin and eosin stain section. The eosin is the pink. It stains extracellular matrix like collagen, a pink color. And then the dark purple color is a nuclear stain, and that is hematoxylin. So this is a very standard pathological stain that you looked at in 201 and 202, but maybe nobody ever explained what you were looking at. Okay? So here you can kind of appreciate, you can even see on this histology, you can appreciate the cilia. So this is ciliated columnar epithelium. Right here is where this transition happens, this little line, and that's this line right here. And now we replace it with squamous epithelium because that pollutant is causing an irritation, and so it actually wants to protect it with an exterior lining, like what you have on the surface of the skin. And if the smoker stops smoking, then you can reverse this back. Okay, so let's look at, and then I'll get your question, Troy. This is from one of the links that I've given you. This is a free access from the University of Iowa. You can see the species is human, the organ is lung. The diagnosis is emphysema, and we're in a primary bronchus. And you can kind of appreciate right here the big picture of the slide. The yellow box is where we are. If we continue to zoom in, we get in a little bit further, you can hopefully see green means good, right? Green means go. This is columnar in phenotype, and over here they're actually getting more flat-like. Squamous means flattened. And so you have another example, different tissue from a different patient, not from your textbook, but just to reinforce the concept of this is a very well-established phenomenon of metaplasia. Yes, sir?
Going back to hyperplasia, you said that...
Hyperplasia.
Yeah. You said that in atherosclerotic arteries, it stimulates hyperplasia to
in atherosclerotic arteries, what happens is you have a normal lining, right? So this is the blood vessel, and normally there's an internal elastic lamina, and you have this layer of cells that lines the blood vessel, and those are called endothelial cells. Remember that from 202? Well, if you damage these, this underlying layer here underneath the basal lamina, these are actually smooth muscle cells, and they migrate out and they proliferate, and they actually close off this lumen with that disease. So hyperplasia of smooth muscle cells is a pathologic condition of an atherosclerotic lesion. Okay?
Why doesn't the endothelial just
That would be fantastic, but it's not capable of doing that. And if it was, then many of you wouldn't have future jobs because there wouldn't be any people with these issues. Okay, so it's kind of a good and a bad, right? But yeah, in other there are some other species where they actually do repair better than us. In fact, just as a side note, what's fascinating about canines is if you have a vessel, and let's say you have a blockage right here, and this could be in the heart. This is actually a main vessel of the heart. The dog heart will actually regrow a collateral vessel over time. And that's why dog models are terrible models to study myocardial infarctions, because they always live. Okay. So there are some species intricacies, but for our purposes, with the Homo sapiens style, we don't do a great job of repairing anything in the vasculature. And that's why we have such issues. Okay? Good question. Other questions?
How long does it usually take from gestation in this case?
It varies. The question is how much time does it usually take for metaplasia response? It varies. So the term chronic it's really a long-term adaptation. And so it's over years that these things take place. Can I give you an exact number? No, it's going to vary from one patient to another. In fact, there could be patients where, they've been smoking for 40 years, and there's no evidence of cancer. There's no metaplasia. Everything looks fine. This is kind of a funny story, and I don't mean it disrespectfully, because this individual donated their body for science, but we get cadaver explants quite a bit in our lab, and it comes from a donor pool, and this agency is called Life Legacy, and so if you're wanting to donate parts or your body to science, you can do that. And so we received some vessels, and we were reading about this, and this was a 77-year-old male who had passed away of natural causes, but it was clearly had atherosclerotic lesions. And on his medical history, he had drank single malt whiskey for about 40 years, and he had smoked for about 20. Well, he quit smoking about 20 years ago, but he kept drinking a glass of single malt whiskey every day. Now, it was kind of interesting. And he quit like 2 months ago. And so the question is, everyone's kind of laughing in the lab, well, is that what killed him? Because he stopped drinking the single malt whiskey? And so it's interesting, and he might have had some vascular issues, and that alcohol was enough to vasodilate him to a point where it was actually helpful. And by cutting it off right away, we're hypothesizing, but it was just an interesting medical history. So for some patients, it could be smoking for just a couple of years. For other patients, it could be smoking for a lifetime, and then it happens, or it never does. Okay? But the word chronic we're going to use a lot. Let me define that. Chronic versus acute. Chronic usually means long-term, like over a period of months to years, typically. Acute means right away. Like an acute injury is something that happens right now. A chronic injury usually is you're exposed to it over a period of time, and then it actually causes damage. Okay? All right. So if we look at cell injury and death, and we look at the different causes, here's a list of the different causes that I put together. Is this all of them? No. But it's pretty much all that would fit on this slide without making it like 6 font. Okay. My favorite one is the bottom one. Aging causes injury. It does. It absolutely does. And every day, your body repairs itself. And as we get older, our ability to repair itself diminishes over time. We will cover a little bit more of that when we talk about cancer. Why cancer? Well, because cancer uses this to its advantage. A cancer cell is your own cell that's figured out how to way not to age. It can replicate unlimitedly. And as we get older, our cells lose their ability to replicate. So case in point, if you have a grandparent or a loved one who's older, what's define older? Over the age of 70, I would consider to be an older patient. And if they have a lesion or a cut, it's not going to heal nearly as well as any of you. And it might be noticeable. It might be noticeable. So I'm seeing that in my parents. I'm seeing that now with just small little lesions that are needing a little bit more attention. Nowadays, you get a pretty decent cut. You put a little bit of triple antibiotic on it, and you call it good, right? Some of you don't even do that. But as we get older, our ability to repair is compromised. Well, hypoxia. We're going to talk about hypoxia. This is low oxygen levels. That can cause damage. Hyperoxia, too much oxygen. This creates free radicals, or what we call these reactive oxygen species, which are these intermediates that go around and actually cause trouble in tissues. Chemicals, harsh chemicals. Some of them could be pollutants. Some of them can be things that you come in contact with on a daily basis, right? If you're of childbearing age and you're working in a laboratory and there's actually a carcinogenic agent or a mutagen that could cause issues at the level of the gametes, you need to be made aware of that so that you're making good decisions about your safety so that you're not causing mutations to the gametes, your own gametes, for future reproductive capabilities. Infectious agents, immunological reactions. There are certain immunological reactions, like hypersensitivity reactions we'll talk about, that can cause cellular damage. Genetic defects. Some of them we're born with. Those could be diseases that we're born with, like Marfan syndrome. Marfan syndrome is a genetic disease, typically of an extracellular matrix protein. Commonly, it can be collagen, different types of collagen. So these patients, their clinical manifestations can show themselves in various ways. Oftentimes, they have aortic aneurysms that form right at about midlife. They can be life-threatening. Nutritional imbalances, even, the way we eat, that can cause cell injury if we don't get the right nutritional elements. Physical agents like trauma or a car accident, obviously. So this list is not all-inclusive. It's fairly comprehensive. And all of these we will cover throughout the semester this spring. So let's look at, if we compare and contrast reversible versus irreversible injury. So on this diagram, we've got sort of three rows. We have the top row, which is showing normal cells. We have this middle row, which is showing this reversible cell injury that can take place. And we have this bottom row that's showing irreversible injury that moves on to necrosis. And the normal cell, you can see all the different parts of the normal cell. You have your nucleus, right? You have your vesicles, you have mitochondria, you have your Golgi and your endoplasmic reticulum. Well, there's two things that can take place when an injurious stimulus shows up that are clues that something's going wrong. Number one is the cells swell in size. And number two is they actually go through what we call a fatty change. Both of these could be reversible phenotypes if you remove the injury. But if you move on and there's irreversible or past this point of reversibility, then you get into this category of cellular death. And in this slide, we're talking specifically about necrosis. Because in necrosis, you actually lose the membrane. you get swelling, and then the membrane actually kind of has holes or ruptures, and the contents start to spill out, and you have this necrotic problem of cellular debris that macrophages need to come by, phagocytose, gobble up, and digest. So we're going to come back to apoptosis here in a minute, but I want to talk about cellular swelling, and I want to talk about this fatty change before we come back to apoptosis. So in cellular swelling, it's exactly that. Water infiltrates, and you get a decrease in mitochondrial activity, so ATP goes down. If you have less ATP, your pumps aren't working correctly, so you get this accumulation of intracellular sodium and intracellular chloride. Well, what does water do when sodium's high? Water likes to follow sodium, and so if there's high sodium levels inside the cell, water's going to rush in, and that's why it swells. Because you've lost ATP production, so your sodium-potassium pumps aren't cranking and creating your correct ionic balance of your cell. Right? Remember that sodium-potassium ATPase that you've learned about like 17 times? You probably should look at it one more time, because these are the prereqs that I talk about that fast, and if you're not tracking, maybe you're like, what do you mean? He said sodium's high. Why is sodium high? Well, because you lost ATP. Well, how's that related to sodium? Well, your sodium-potassium pumps aren't working. Oh. And now I'm already on like 3 slides forward. Okay, so remember, if you're struggling with one of these concepts, put a little note, so look back at ionic balance in a normal cell. Okay, typically sodium is high outside the cell, and potassium is high inside the cell. Remember that? So the pump takes 3 sodiums out, and it puts 2 potassiums in, and it takes ATP to run that. Okay? So here, we lose our mitochondria. So we get this increase in water flowing into the cell. This increases our pressure, our turgor pressure. The pressure inside the cell starts smashing the contents against the membrane, right? So because there's more water inside, the cell kind of gets diluted, so it may have a little bit more of a paler color, or a pale color under histology, because there's less stuff inside and more fluid. And it increases in weight. Why does it increase in weight? Because water is really heavy. In fact, tissues that are made up of cells, when they're going through a necrosis process and the cells are swelling full of water, that tissue becomes heavier in weight. And if you have inflammation and you have swelling, you know that, you know what, my watch doesn't fit normally because my arm's swollen. Or my foot, I twisted my ankle and I did trauma to the muscle cells within my lower limb, or the ligaments, or the tendons, and now they're swollen. Right? Now my shoe doesn't go on correctly, and I can tell. Well, so the whole limb could swell, but at the cellular level, that thing is swelling, so it weighs more because of the water weight. Again, this is reversible if you can repair the process or remove the injury, or if the injury was acute, like a sprained ankle, well then over time, as long as you don't keep spraining it, it will actually recover.
If it was something like a sprained ankle, how would that cause mitochondrial?
Well, if it's a traumatic injury to the cell membrane, then you compromise ionic balance. And if you compromise ionic balance, you can't shuttle ions, you can't create the gradient to make ATP. Does that make sense? So that cell is done. And macrophages come in, clean it up, and then new cells will be replicated from existing cells and you'll repair. Well, that sprained ankle of a 75-year-old will heal a lot slower than it does of a 7-year-old. Right? That's kind of that aging process that I was talking about. All right, the cells themselves create these spaces, right? These vacuoles that are just empty spaces that used to have cellular organelles and now they no longer do. So let's take a look at this histology. Let me dim the lights real quick so that you can see this. On the far left is normal kidney tubules. Normal kidney tubules. These are cuboidal epithelium, if you remember back to 201. Well, a long time ago, man. Okay. But if you have that textbook, you can look it back up. Okay? So, normal kidney tubules on the far left. What I want you to be able to appreciate is kind of these boxy-looking structures with the nucleus right in the middle. You kind of appreciate down here where the box is, right here, right here. Here, you can see that these are swelling, they're enlarging, and the color is actually fading because you're increasing the water content. This is actually, in B, the early ischemic injury of a kidney tubule. If you cut off blood flow to the kidneys, you could actually have kidney damage. Okay? It's actually one of the problems in trauma, like aggressive trauma, where the patient is bleeding out, and they save the patient, they get him to the OR, they stabilize the patient. Now they're worried, how long was blood flow ceased? They worry about the heart, the brain, and then the next organs they're concerned about are the kidneys. They want to know, is kidney function working? It might be a couple days, if all goes well, it might be a couple days before that patient actually urinates, before GFR comes back online. Okay? So this is reversible here, as long as you can reestablish blood flow. You've got, the big ones is the swelling, the enlargement of the cell. And you can kind of start to see there's a little bit of loss of the integrity of the membrane. Over here, this is irreversible, and you can see that this one's really swollen, this one's completely compromised. You can't even really make out where the architecture of the tubule network is anymore. So this is irreversible, this is reversible, and this is normal. All right, fatty change, number 2. Item number 2 in necrosis. Up top, anybody know what this histology is up top? What is it? It is liver. Nicely done. So this is liver, normal liver up top. On the bottom is fatty liver. Oftentimes due to excessive consumptions of alcohol over a long period of time. It's not cirrhotic yet. Okay, this would be an alcoholic hepatitis liver. And we'll talk about those differences when we get into the kidney section. But what are you noticing? Well, you're noticing that this normal liver has these large vacuoles that are filled with lipid. All of these round white spheres are all vacuoles known as lipid vacuoles or fatty liver disease. Well, if you remove the injury, in this situation it's a chemical, which was on our list, in the format of alcohol. If you remove the injury and the patient stops consuming alcohol, then this will reverse back. Where it becomes a problem and it's non-reversible is when the lipid fatty change turns into a scar. And you get scarring of the liver, fibrosis of the liver. That is no longer reversible. And so those patients are ones that typically need a transplant. Okay, back to apoptosis. Programmed cell death. This is very organized. It's very different than necrosis that we looked at. You get this blebbing that takes place. We're starting to compare and contrast necrosis versus apoptosis. So here's our necrosis pathway. I said that the membrane is gone. It's compromised. There's holes in it. Stuff can leak out. In apoptosis, you never lose the integrity of the membrane. Instead, you get this blebbing, and then you send out an apoptotic body. Okay, it's kind of like this little escape pod off the mothership, and it's nice little compartments of internal cellular organelles that can get nicely recycled. You still recycle parts over here, but there's a lot more energy to rebuild than over here, where you can just kind of borrow one piece here and move it to a different cell. So the big ones are, you get apoptotic bodies. Instead of swelling, you actually get slow shrinkage that takes place over time, because every time an apoptotic body is shot off, this main cell gets a little bit smaller. And the phagocytes, the macrophages come in, they kind of ingest it and recycle the components. So this table is a really nice table that helps to outline some of these details explicitly. So you can see on the left is a column. Columns go up and down, right? Apoptosis, and on the right is a column that says necrosis. So let's look at this. Apoptosis typically affects a single cell at a time. Could it be a group of cells? Yes. Could it be a group of cells that is in between two digits? Absolutely. Okay, but it's unique to a single cell at a time. When we get to immunology and we look at T cells and B cells, we see a lot of apoptosis there. Our immune system uses a tremendous amount of energy to actually destroy apoptotically self-reactive clones, self-reactive lymphocytes that are going to go and kill off your own body cells. Then it programs it for apoptosis. And then it starts over with the scratch material and builds a new one. Why does that work that way? Well, it wants to be very clever and create all these different formats so we can kind of battle all these different bugs. But in the process of being overly creative of how to make numerous types of reactive clones or reactive lymphocytes, a lot of times you react with your own tissue. So we need to screen that, and we program the ones that are self-reactive for apoptosis, and we start over. When one leaks out, then you have an autoimmune disorder, like type 1 diabetes, for example, okay? Or rheumatoid arthritis, multiple sclerosis. These are all usually due to a leaky immune system where we didn't catch it apoptotically, oops, over here, and we didn't program it to go away. And now it's out there causing problems. Okay? So apoptosis is a very, very beneficial thing for us as an organism. There is no inflammatory response. And next week we're going to start, or in the next week or two, we're going to start looking at inflammation. Here we don't see any inflammation. We get cellular shrinkage. We get the blebbing, but the membrane stays intact. Here you've got an increase in mitochondrial membrane permeability. This releases these pro-apoptotic bodies. You condense the DNA and fragment it so it's more easily to recycle, and the neighboring cells ingest these little apoptotic bodies. In contrast, over here, usually it's a whole tissue. There's a large inflammatory response with necrosis. You get swelling, loss of membrane integrity. The organelles and the lysosomes leak. You get random degradation of DNA. It's not organized where it condenses. And then the lysed cells, these are not lysed. These actually shoot out little pods full of contents. These are lysed, and macrophages have to come in and scavenge things up. And then here.
When you get this clarification, the point building, you need to say that like that's those pictures of the membrane just like kind of leveling off.
Yeah, the membrane blebbing is the format or the formation of kind of like a pre-apoptotic body, where this is eventually going to come here and pinch off and form its own little thing. Okay, so it's a membrane blebbing is the cell kind of trying to get ready to go into an apoptotic body. It's a pre-apoptotic body. You may see some blebbing early on in necrosis, but it quickly doesn't do anything. It starts that little process of maybe a little pooch, and then it just sort of loses the integrity of the membrane. Okay? So, along those lines, these two scanning electron micrographs, and then I'll get to your question. So, these are both taken at the same magnification, 5,000x, or they're magnified 5,000 times. Scanning electron micrograph shoots electrons at the surface of this object. This happens to be a cell. Which cell is undergoing necrosis and which cell is undergoing apoptosis? So talk amongst yourselves and tell your neighbor your answer, and then tell them why. How could you defend that? got an answer and they're willing to defend it? Which one is necrosis? Who said that? B. Why? B. She says B because the integrity of the cell membrane is compromised. How many of you would agree with that? How many of you would say A? Okay, a couple. Why would you say A? Cellular enlargement? Well, so necrosis would have cellular enlargement. I would say they're approximately about the same size from this picture. But this right here, what is this? That's a giant pre-apoptotic body about to come off. And see all these little black holes? You're looking right through the cell membrane into the inside of the cell. So this would be a necrotic response, and this would be an example of a classic apoptotic body. Okay? So just to give you guys some pictures to put with each of the descriptions. This gentleman had a question.
Yeah, it's kind of like backtracking a
That's
little
okay.
bit. I was just wondering, what was the purpose of lipid vacuoles and fatty change? Like,
What's the purpose?
Yeah.
Why does it happen?
Yeah.
It's just a pathologic response to when there's an injury to take up space within the cell. And so, any of the available lipid gets packaged up. So it's not necessarily a good thing, but it's just something that takes place. You see it most pronounced in like the liver image that I showed you. It's pretty obvious. You can see all these fatty lipids. The other reason that happens in the liver is because of the liver's role in lipolysis and lipogenesis. So there is a little bit more of a role there within liver tissue. But it generally will happen in all cells. They do, cells do have fat, they do have cholesterol because they need that in order to manufacture the cell membrane. And so there's an upregulation where the cell, I think, is trying to say, I'm going to repair myself. We're going to upregulate the amount of lipid that's available, but it doesn't help.
Going back to these two pictures.
Okay?
You could also say that this is nearly done through reversible.
I can barely hear you. You got to speak up. A is what?
A could be just a cell that has undergone reversible injury, but it could go either to necrosis or apoptosis.
I can barely hear you, but I think what you're saying is, did it go through injury, reversible injury, and now it's coming back?
No, it could either go to necrosis or apoptosis.
Oh, it hasn't decided yet what it's going to go? If that was the case, this blebbing wouldn't be so pronounced. It wouldn't be, 15, 20% of the cell. So the little early blebs are going to be really, really small. This is a pretty significant bleb. Okay? So this one would be apoptosis. This one would be necrosis. All right. Lastly, we're going to take a little break. Necrosis. We use words like moth-eaten because you can see the membrane of the cell has been completely perforated. This is a picture of kidney tubules, slightly lower magnification. Okay, but you can kind of appreciate the fact that all of these tubule networks, number one, are anuclear. There's no purple dots. It's pretty much all pink stain. Now, pink was the extracellular matrix or the contents, and the dark purple hematoxylin is the nuclear material. And so without any nuclei in this, you can be confident that the membrane itself has been compromised, and all of the nuclear material has actually been leaked out or degraded. So in necrosis, it's irreversible. You get nuclear degeneration, where they're anuclear. We saw that on the far right slide when we looked at the three panel of the tubule network of the kidneys, and we kind of went from normal to reversible to irreversible. We had far less nuclear content on the far right. Okay, panel C on the very bottom. And so that's exactly what you're seeing here. It looks moth-eaten. The dead cells become calcified as they degrade into fatty acids, and the calcium actually saponifies and becomes soap. The nucleus degenerates, and you lose the cell. It starts out as a swelling, and then it just sort of disappears. Okay? When we come back after this little break, we're going to talk about the different types of necrosis clinically.